What's up, everyone? Week number 12 in this debriefing. Another fun and floatful week here at hospital.
Honestly, it's been flying by. It's wild how all these 12 weeks just condensed into time. And next week is going to be my last week here. Pete's extending, and we'll dive into that episode next week on how all that is going in the transition. I had a pretty interesting case this week around where I've taken care of this patient a few times and she's still here. So things aren't looking the best. Originally came in for a tumor lysis syndrome. So 2 days before she got her first dose of chemo, and with the chemo, what happens is it just dissolves the tumor. You could have high lactic acidosis, some other mineral off balances, and they go into the hospital. So she almost went into a septic shock, metabolic encephalopathy, and they can't figure out why she's GI bleeding. They did EDG, colonoscopy, they did some colon ulcer clippings. They stopped one of her medications that she takes for the gallbladder, pancreas. She has only one kidney. Her kidney started working again, so now they don't want to do any more contrast dyes, and they're fighting this balance beam. She doesn't have a great cough, or I should say not cough, but swallowing. So they wanted to do like a video camera swallow. They couldn't pass that down. She tried 7 times. So the day that I was leaving, they're supposed to do a small video swallow to figure out where the heck she's bleeding. Maybe it's a small intestine thing, but it's just so unfortunate where is this patient headed? Meaning she has the cancer. So now she's getting anemic from the multiple myeloma. She has only one kidney and it's not working the best, which also affects anemia. And now she has all this going on as far as trying to figure out a bleed. So we're just giving her platelets and units of blood every single day. And the family is very hopeful, but it's going to be a tough road for this patient. So that's the patient I had. That's like a highlight of my 3 shifts.
Yeah, it's crazy because we could do so much tests, so much scope, so much images, and we sometimes still can't figure out how to help somebody. And that's with everything. Sometimes things just come out of nowhere. I feel like when you read over notes and you see like encephalopathy, that's almost like saying there's something going on neurologically with this patient, but we're not really sure what's going on.
Yeah.
Is it because the ammonia is high? Well, the labs show that there's no high ammonia. What's going on? The patient has altered mental status. There's these symptoms going on, and yet we don't have an explanation for what it is. It's almost like those idiopathic diseases that we just say idiopathic anemia, where it's just anemia out of nowhere or whatever else there is. It's crazy because, like I said, there's so much stuff we could do, and yet we can't always figure it out. And it just shows us how different we are as humans, and it's not a one-size-fits-all for humans.
And that's a perfect example of that one patient. I don't know if you ever taken care of her, but she has trimeningeal neuralgia, which is twitching and pain from a nervous system standpoint. We can't find out the source of it. So what do? She's been on like Q3 muscle relaxers and another muscle relaxer, and all we're doing is just giving pain meds. She's getting high off it in a way because she's just clicking the clock, and we can't figure out the source of what's going on. Yeah,
especially with the elderly patients, you have to figure out, when you're at that point, you have to figure out if we already did this much test, should we keep going, or is these amount of tests affecting the quality of life? So it's kind of up to the patient, you could say, and the family how far they want to go, because we could keep looking, we could keep drawing blood, we could keep looking at images, we could keep doing studies, we keep sending down different things. Doctors have different consults, but it ultimately comes down to the patient and family. How much are you willing to do to potentially find a solution, and if there even is a solution? And that's kind of where she's at. Is the quality of life worth sacrificing for the time that she has left? I'm not sure how old this patient was, or where her you could say total prognosis was, or whatever like that. But it's crazy that you reach a certain age, and that's kind of how you have to think about life.
Yeah, and what happens is doctors come in every couple of days, assess, maybe family wants to do palliative. They refuse. Okay, let's continue. A couple of days later, let's discuss code status, and it's this ongoing thing to see what is realistic expectations of where we want this patient to go.
Yeah, because each procedure has its risks. You might go in for endoscopy or a colonoscopy or EGD, but let's just say your platelets are low and your coagulation factors are off, but they want to do it just to risk it, and they pop a varice or something happens, and you were going from anal times 4 completely mobile to now potentially spending a week intubated, 2 weeks intubated. And that's kind of a risk involved with everything.
Yeah. How are your patients?
I had a very interesting week. I've been floating a lot. The QT wasn't very high in the ICU, and I got floated to step down quite a bit. And also, what I noticed in step down is, because you know how in the hospital there's 2 step down sides, the north and the south.
Yeah.
One of the sides they made more of a step down. The other one they did a telemed-surg because they had just so much telemed-surg patients where they had to kind of almost close down half the step down because they didn't have a lot of step down patients. It was mostly overflow of med-surg and tele. Luckily, I wasn't there. I was on the more of the step down side, but I had a really cool patient when I did get floated to the step down side, or not step down side, because I was with you in the med-surg / tele side when we were together. So I had a really cool patient. I had a patient in his late 70s, a really amazing guy, and I was talking to him, and he had stage 4 lung cancer, and I was kind of talking to him, and I asked him how he feels about that, how his wife's taking it, and he was very chill, very relaxed, probably the most calm patient that I've had. So I was thinking maybe he's got like quite a bit of time to live, maybe things are going good, and then he just broke the news to me. He's like, yeah, I got like 2 months to live. And I was like, damn, 2 months to live, trying to put myself in those shoes, and I really couldn't. I was trying to think about how I would feel having 2 months to live, and I couldn't really picture it because I'm 27 years old, gonna be 28 next month, and I just couldn't comprehend how it would feel to have 2 months to live, because I expect to live for another 70, 80 years, maybe even more. And
it's great to see that he has integrity with his life, where he could be at peace during that time. That's very difficult to some people.
Yeah, and plus when we get floated to oncology, we see people with stage 2, stage 3, or even stage 4, and they're just in a hospital, you could say kind of miserable. They can't do anything for themselves. They're very depressed. But this guy was very calm, very relaxed. And I asked him how he feels about it, how his wife's taking it. And he's like, we're taking it great. I'm okay. I'd rather get diagnosed with a stage 4 than a stage 2 and a stage 3, because he doesn't want to go through the chemo, because he was saying that if it was stage 2, stage 3, or stage 1, he would probably go with the chemo and radiation and go that route. But he personally prefers this route because he's not sure what the outcomes would have been to the chemo. Would he live a happy life? He wouldn't know. So he's actually kind of glad, you could say, that it's stage 4 and that he has this much to live, because he was ambulatory. He's 8 times 4, very little forgetful. Maybe it has something to do with the metastasis that he has going on, but he was still pretty sharp for what was going on. And so I asked him, like, why is he okay with it? Why is he so calm? And why is he just okay with this? And he told me that he's very calm and okay with this because he financially set up his children, his grandchildren, for success. He has a handful of grandkids that he was able to help them with college. He was able to help his kids with college, and he was very financially, I don't know about very financially well off, but he was financially off. He was able to do these things, and that was one of his biggest worries. He said that when he got married and he started having kids, he put his life a little bit on the back burner financially. He didn't buy all these toys that his friends were buying, like 4-wheelers, motorcycles, all those things that he wanted. But he knew that there's a bigger picture in place, so he would just rent out those things for a small short of time. And he's saying that is what really made him okay with life, because he enjoyed his life and he was good financially. So he didn't want to put his children or his grandchildren in a worse financial situation than he was, because he felt that he enjoyed life and where he was financially, and the worst thing for him would be to see his kids struggling financially, because he saw it as it would be almost unfair that he was able to live this fruitful life, but then when it comes to his kids, they weren't. So he always made sure that they were financially well off.
It's amazing how this continuation of life is happening, where you are born and you're being given, you are working for something which you earn, and then towards the end of your life, you're giving back to that next generation, and you're explaining, and he feels so good for that.
Yeah.
And I heard my grandparents talking about that too. And when we have coffee or whatever, when I'm back home, they always mention that, like, they loved giving back, or they supported me or their kids, and they have homes and they have kids. And yeah, it's awesome that the integrity is there for these older patients.
Right. And it was very interesting to me, because a lot of times we always push things like live in the present moment, spend the money that you have, because it's money. It's just a way to transfer things. And sometimes you have to just step back from that and maybe put some money aside. So this kind of made me realize that I always tell people, hey, like, spend the money, have some fun, do this, do that, And I haven't really told anybody for a while to save up and save money just in case. So this was like a good eye-opening situation, and he kind of brought me back into reality, saying that, hey, it's not always about the present moment. You have to think about the future as well with finances. Because like I said, like a lot of times you always say, hey, spend some money on yourself, do this, do that, which you should, but also you have to take into consideration the future and the future life. If you have kids, if you're married or planning on having kids, it's a good feeling to spend money on yourself, but it's a really good feeling to have when you're able to give that money away to your kids, to your loved ones, and see them enjoy that, because it's almost like you're living through them at that point.
Yeah. Have that emergency fund, boys and girls.
Yeah,
I had two random events that happened as well. The beginning of the shift, I changed an ostomy that had a fistula. So I don't change ostomies often, but I noticed that she's having stool from both the stoma itself and then underneath. So it's almost like the intestines just fistulated and made a tear, and there's poop coming out both sides. So I noticed that, changed that. And it's so funny where the next shift, the next day, I went back to DOU and I told the nurse about it, night shift nurse, and she didn't know that's going on because it was already lost in the report. And I'm like, man, I hate when that happens. Like, let's pass that on and take care of the patient. Side note.
Or at least give your patient back, because you were there the prior night and you came back the next night and they didn't give your patients back.
I spoke up about that.
Yeah.
And it's funny where they said, yeah, you're right, continuum of care. Took me over to the other side of the unit. Okay, cool, I'm going to be on the same unit. Let me get my same patients back. That didn't work out. Yep. So
the good old way.
Exactly.
Not to like talk down it's a great facility. Nurses are amazing, but sometimes they do things that's backwards.
Also, I had a patient that had a tick out of nowhere. I was taking care of this guy because his Foley got discontinued, soiled. It's like 5 a.m. I'm looking at his arm and I'm looking that there's something that doesn't look like a mole and has legs sticking out. And I touched it and it moved. And I'm like, ugh. Called the doctor. I guess in California there's no Lyme disease, so we just went ahead and not even isolation, just pulled that effer out.
There's no Lyme disease? Like, doesn't exist?
It doesn't exist in California. Yes.
Interesting.
So if you have a tick out here in Cali, you shouldn't be worried about it today.
Maybe tomorrow.
In general, you could just take it out. Another patient I had that really stood out to me in these past couple of shifts is a CHF that continued to come in four out of the 4 weeks. Every single week he got admitted, and I talked to the guy, ate a slice of pizza and 3 chili dogs, went into CHF overload from all the sodium, and I talked to him about weighing himself and tracking his sodium, and I went over like food labels with him and read it off to him, and he got yogurt, and to see how he could maybe add sodium to prevent this from happening, or taking a double Lasix dose if he goes over 3 kilos in a 24-hour period or whatever it is. And he's like, wow, thank you so much. No one told me this. And it's just like, we forget as nurses, because we're so busy with all these tasks, that this education part matters so much. Like, yeah, we're replacing K and hanging IV fluids, and we need to get this lactic down, troponins, EKG. But what about the continuation of that person's care? How is he going to take care of himself at home? We kind of forget that part because it's irrelevant, because we don't see the patient. But if we empowered the patient with education, they could be better off with, in this case, he said he wouldn't have got admitted 3 additional times because he didn't know how to take care of himself. So he felt hopeless in the process. Like, how do I do this? And now he felt empowered, which is amazing. We'll see if he comes back. But education is important. Like, take time to sit down with your patient and see if he actually knows the disease process that he has, and question him. Okay, if you have diabetes, how do you take care of diabetes? What do you do when you have low blood sugar? Like, help them to see how well they could critically think about their disease process, and you'll know where the education level is and what you need to educate them about. Yeah,
I think nurses overlook the education aspect, because we forget that not everybody thinks like us and not everybody has the same knowledge as us. Because we're nurses, we're around the same stuff over and over and over again, so it's almost like common sense to us. And we forget that these people, these patients, are not around this stuff every day. It's not engraved in them. And I think that's what happened. That's what happened with your patient. And maybe they overlooked it. A lot of nurses assume that since they know it, that the patient is also going to know it. Because a lot of times we're younger nurses. These nurses are in their 20s, 30s, and the patients are in their 50s, 60s. So a lot of times we assume and think that the patient already knows this information. But they really don't. It's because we're surrounded by it so much and so often that we just think it's just universal understanding, but it's really not.
Yeah.
Yeah. And that night that I was with you, I got floated to oncology afterwards. I had a really interesting situation with my patient as well. So this patient put a call light on twice. The first time somebody else answered it, so they're going to be there in a little bit. He complained that he had some blood in his stool, and that is an emergency situation. But given his history, I was able to look through his notes. That's what he came in for. Everybody was aware, so we told him that, hey, we'll be there in a little bit. Hit it a second time, so I was like, screw it, I'm just gonna go in. And right off the bat, we had like a negative interaction. He like raised his voice, and he was surprised that I was there. He told me to raise my mask and put on gloves when I speak to him, and just went off on a bad foot. He was very frustrated that I was going to be his nurse. Nobody informed him that, hey, it's 11 o'clock, we're gonna switch nurses. Nobody updated him on that, which I understand where he was coming from, but I literally just got there, and the nurse was busy in another room. I was just entering the call in the meantime, just for a common courtesy. And I even told him, hey, I'm gonna be your nurse. But he was a little bit shook and upset because this bloody stool was a new thing for him. He had it so he came in the same day, and he was still having it. It's like his 4th or 5th bowel movement with bloody stool, and he was like, we gotta do something about this. I need to speak to a doctor. I gotta figure out what's going on. I told him to, hey, just
11 o'clock at night.
Yeah, I'm like, it's 11 o'clock at night. In the notes, it said doctor spoke to you from a doctor. In the notes, also saying that if your hemoglobin is less than 7, we're going to give you blood. I'm going to draw your blood at about 1:30 because you had this bowel movement at 11. It's going to take like about an hour for it to kind of recalibrate because you just lost some blood. So let's give your body time to process this loss of blood so it could maybe stimulate some blood production. So he didn't really like the way I said that. So we were having this negative interaction between each other. I was frustrated. He was frustrated, but I remained calm. Internally, I was super frustrated at him. And when I left the room, I took a deep breath. I'm just like, this is how my shift's going to start when I'm getting floated. I was super frustrated. My nerves were up, and I was like, all right, I'm just going to do, let's just say, just what I need to do with this guy. I'm going to minimize my interactions. I'm just going to do what I have to do, and that's about it. And then later throughout the night, his wife came. Same ordeal. It seemed like they were really frustrated with me for really no big. I didn't do anything wrong, and that's why I was really frustrated. But I kept answering his call-outs, kept helping him out, give him some more information, and throughout the night he kind of relaxed. And it was actually nice because like around 3-4 in the morning, he actually apologized. He's like, I'm sorry we got off on his bad note. I didn't mean to come at you like that. You're doing a great job. You're keeping me informed. I was just really frustrated at the situation. And I told him, it's okay. We're here for you. It's just, I know you're going through a lot. I didn't take it personally. So some nurses wouldn't approach the situation like I did with a calm demeanor. A lot of nurses would kind of flip it around the patient and just kind of bite back for the most part. So it just kind of shows you when a patient's giving you a hard time, just take into consideration that they're going through a really tough situation. He was newly diagnosed with cancer. He had a lot of stress on his shoulders, and he just happened to take it out on me. And I kind of understood that. Even though I was frustrated in the beginning, I kind of calmed myself, and I realized that, hey, he's in a worse situation than I am. I'm just having a bad patient. You see, he's having a bad part of life. So it just kind of shows you, just stay calm. Don't egg that patient on. Just do what you have to do, and just inform them. Be calm. Be respectful, and they'll see that, and they'll realize their mistake without you pointing it out.
And it teaches you to not react.
Yeah.
That situation is perfect. You mentioned you're just teaching you how to kick it back and let your emotions calm down and respond. And some nurses kind of back talking away to their patient. They give the same energy back. It only ruins the communication even more in the relationship that is already on. It's a rocking boat.
Right. And it just keeps the frustration going, because now instead of this guy being frustrated for 3 hours and you're egging him on, you're frustrated, he's frustrated, and just adding on to that, now you're both gonna be frustrated for the next 6 hours. So just let things go. They're patient. They're in a tough situation. So just don't let it get to you. Because sometimes I do, and if I do start to feel it gets to me, and I start to think about something smart to say, usually I just leave the room. I tell them, hey, I'll be right back. Because when I was a younger nurse, I kind of didn't hold it back as much, and patient would see that, and I would just make them more upset. It took me like a solid couple of years to realize that, hey, that's not the most therapeutic ways to communicate. So if I get frustrated, I feel my blood pressure get up, I feel warm, I just step out, take a breath, and say, hey, just stay calm. The shift's gonna end. Just let me do my care and just move forward.
Yeah, and that's how the week flew by.
Yeah.
Ready for another one next week?
Always ready.
All right, guys. Hope you guys enjoyed this content. If you guys did, give it a like, comment, share. Let us know maybe what you want to hear next. What was your favorite part? See you on the next one.
Thank you so much. Peace out.